Hi, my name is Naval. I'm a faculty in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. It's a pleasure to speak to you all today, covering the year in review with Dr. Nee Love. I will be focusing on available and emerging non-targeted therapies for acute myeloid leukemia, which is an area of great interest for us at the MD Anderson Cancer Center in Houston, Texas. I know many people are curious about how the Department of Leukemia works at the MD Anderson Cancer Center in Houston, Texas. We do have probably the largest group of leukemia experts in the world in the Department of Leukemia at MD Anderson, and also a very, very extensive list of clinical trials. Our focus historically and continues to be the development of novel targeted and immune therapies and combinations, especially with a focus on phase 1 and 2 to try to develop new paradigms of treatments that can then move into registration studies. And we do get a lot of patients, almost 70% of our patients coming from out of the city and 50% from out of state. And so we really do try to develop attractive clinical trials beyond the current standard of care randomized studies so that patients who travel all that distance, spend money, logistical issues, will get a treatment that hopefully will be something beyond what they could have got at their local academic or community center. And of course, with all the progress happening in leukemia in general, not just acute myeloid leukemia, but all of the fields, it's a very, very exciting time for myself and many of my colleague researchers who are working in this field. So I'm going to start with probably the medication that's discussed the most in most acute myeloid leukemia settings. This is a drug called venetoclax, BCL2 inhibitor. The pivotal study of azacitidine with venetoclax, called the VIALE-A study, that was led by my colleague and friend, Dr. DiNardo, led to the frontline approval of this combination in newly diagnosed older, unfit acute myeloid leukemia. We see here the response rates were all improved. The CR/CRi rate was 66 versus 28%, so more than twofold improvement. CR rate was also doubled at 37 versus 18%, and there is an overall survival improvement with median survival of 15 versus 10 months with the combination. So this is very good, led to the approval, has been used extensively. Responses were seen across most molecular subgroups. However, what we have started to see now with long-term follow-up, this was data presented by Keith Prats at the ASH meeting in 2022 December, and then published recently earlier this year, with a median of 3.5-year follow-up, 43 months. What we see is that the median survival at 3 years with the AZA/VEN combination is about 24%, as compared to a median survival at 3 years of 8% with AZA alone. So yes, this is better, 24% compared to 8% 3-year survival. However, it's also not optimal. We do not want to be at 24% survival at 3 years in the future. And so there are efforts to see how we can improve on this. And also important to realize that AZA/VEN improves survival, but on its own may not be truly curative for a large population of patients. And we do continue to see relapses occurring with this treatment out into the 3rd and 4th year of treatment. So this has led to a lot of efforts to understand who are the patients who seem to benefit the most and have the most durable responses with AZA/VEN versus those who may have some response benefit, but the responses are short-lived and they relapse earlier. And what we found is, based on a molecular analysis that was done on the phase 3 VIALE-A study, there were actually 3 groups of patients who had different degrees of benefit with aza/venetoclax. So the first group is the one that seemed to really have minimum, maybe even no benefit with the aza/venetoclax compared to azacitidine. These were TP53 mutated, where the median survival was only 6 months. This is actually similar to median survival of 6 months seen with azacitidine or decitabine alone. So this population really needs new treatments, new combinations with or without venetoclax. The middle group is those who have signaling mutations, so the FLT3 and RAS mutations without a TP53. These patients had some improvement in survival, about a 12-month median survival, better than AZA alone, which is 8 to 9 months, but definitely needs improvement. And then you have the others who have none of those 3 difficult mutations, no TP53, no FLT3, RAS. This is usually enriched with IDH1, IDH2, NPM1 mutated. And here you see the median survival is better at 27 months. And I think this is really important because this will be kind of the groundwork on which we can then build combinations with targeted therapies, immunotherapies, to know within each molecular risk group how we can further improve on that. This has now also led to a better understanding of resistance of venetoclax. So a lot of this work was done by Andrew Way in the group in Australia, as well as our group here at MD Anderson. We have now understanding of some of the major mechanisms of resistance. These include mutational resistance, such as TP53 mutations or mutations in activating kinases like the RAS-MAP kinase or FLT3, but also morphological changes such as monocytic differentiation, which seems to be resistance to venetoclax, or upregulation of other anti-apoptotic proteins such as MCL1, BCL-XL. And the nice thing is that we actually now have numerous combinations that could be used to overcome some of these resistance. I will mention one because this paper was just recently published this year, looking at the clinical combination of azacitidine venetoclax with FLT3 inhibitor. This was based on very strong preclinical rationale that resistance to FLT3 inhibitors often occurs through multiple different on and off target pathways, including RAS-MAP kinase, BCL2 upregulation, and on-target resistant mutations. And so we then took this into the clinic in a combination study of AZA venetoclax with a targeted, highly specific, potent FLT3 inhibitor, gilteritinib. This data was published in the JCO actually earlier this year. And what we see is that the response rates with this combination are much better than what we get with azavenetoclax and FLT3 mutated. Historically, the response rate is a CR rate of about 30-35%. And now we're seeing CR rates of above 90% with the addition of gilteritinib to the backbone. Of course, we had to dose modify the venetoclax down to 14 days to allow for the addition of gilteritinib without significant myelosuppression. And we are now seeing good count recovery. And remember, these are older, unfit patients. So to see a median overall survival here at 2 years of almost 70% is much better than the 25-30% we have seen with the VIALE-A. So this has now led to randomized studies looking at this combination of azavenetoclax gilteritinib versus azaven. And I think this will hopefully establish a new standard of care in the future, especially for some of these FLT3 mutated. And this is just one of the efforts. Similar efforts are ongoing with the addition of IDH inhibitors, antibody drug conjugates, immunotherapies to the azaven backbone to boost that 24-25% 3-year survival to something higher, 50, 60, 70% in the future. Now, at the same time, there's also an effort to see if we can get away from IV therapy altogether. We all as physicians and patients like oral therapy, especially if it can be delivered in a safe and effective manner. So this has led to a combination of oral decitabine with venetoclax in older unfit AML. So the background here is that there is an oral agent called oral decitabine, which was approved by the US FDA for frontline high-risk MDS patients, but seems to have a PK equivalence, almost 99% PK equivalence to IV decitabine. And so it was a logical step to say, could we then use this oral decitabine instead of the IV HMA in combination with venetoclax in the older unfit AML? So we did this study at MD Anderson looking at 52 patients. 42 of these were frontline. These were definitely high-risk, older unfit patients, median age close to 80 years, so even older than what we have seen in the VIALE-A study. And we did have a small population of relapsed refractory AML. Importantly, this study also allowed patients with secondary or therapy-related AML, which were excluded from the VIALE-A. So this is a higher risk population, older age, also enriched with secondary therapy-related AML than the VIALE-A population. And we gave the oral decitabine per the label dosing that's approved in MDS, which is 5 days of the oral decitabine in combination with venetoclax, given for 21 days with the bone marrow done on day 21. If that marrow showed remission or clearance, we would interrupt therapy to allow for count recovery. So overall, we see that the CR/CRI rates are quite similar, about 60 to 70%, very similar to what has been seen with IV azacitidine or IV decitabine with venetoclax. And of those who had a MRD, measurable residual disease assessment, it was negative in about 1/3 of the patients. Median overall survival is close to around 13 months, a little lower than the 14.7, 15 months with the VIALE-A. And this is probably attributable to the older age of this population, as well as the allowance of secondary therapy-related AML, which were not allowed in the VIALE-A. In general, well-tolerated combination looked like what we see with azaven. some cytopenias, mucositis was seen. We did see infections, febrile neutropenias, bacteremia. These were all generally manageable, but again, just highlighting that because this is oral did not make it safer than what we see with IV HMA ven. It's just easier and logistically better, but you still have to expect those same febrile neutropenias, bacteremia, sepsis, cellulitis, infections, and either prophylax or manage those appropriately. But all in all, I think suggests that this combination of oral seems quite similar and equivalent to the IV HMA venetoclax approach.
So, just a couple of follow-up questions. First of all, are you able to access this regimen, outside a trial setting right now? Are you using it? And if not, would you like to?
I don't think we can access this yet outside of the trial regimen. We are enrolling most of the patients who are getting this on this ongoing clinical trial. There is also a larger multi-center clinical trial that is close to completion looking at this combination, and we hope that that trial will support a label expansion or an NCCN guideline, at which time then hopefully this could be used in a routine practice. I think there is one important thing to be aware of is that even though the decitabine is oral, yes, it still is myelosuppressive, the combination. So one should not think that just because it's oral, this has now become much safer. Actually, the safety is the same, and these patients still need monitoring. And one of the concerns we have in the academic setting sometimes is that because it's oral, physicians or patients may get the feeling that we can just take this pill, come back in 2 to 3 weeks. That's not the case. These patients still need lab work, usually daily for the first 4 to 5 days for tumor lysis, cytopenia, and then after that, twice a week or so. So oral, more convenient, logistically easier, but still needs to be monitored as we would do with IV therapy, at least for that first cycle.
Kind of curious if you sort of take a step back and just think about these patients, confronting the diagnosis and all the financial, social, all the issues that come up. Putting aside the lab data, what have you observed in terms of quality of life? Obviously, you would think that, not coming to clinic would be beneficial, but I'm just kind of curious in view of all the other issues they're dealing with, is it really a substantial benefit or maybe not that big a deal?
Yeah, I think that's a great question. I think the benefit is more in the subsequent cycles. The first cycle, and we at MD Anderson, who have probably done this combination the most to date, still admit these patients because the toxicities that happen are not different with oral and IV. We still see cytopenia. We need transfusions. We need to do hydration, tumor lysis. So for the first cycle, effectively, it may not matter to the patient. They are going to be in the hospital for 28 days. So it's oral, IV. It's not going to change things. However, for subsequent cycles, I think it's a nice advantage to them because they can be outpatient. They don't have to come for those 5 consecutive days of IV decitabine or 7 consecutive days of IV azacitidine, and they get much more time away from the clinic and from the infusion center. So I think it helps their quality of life, their expenses, their travel, their logistics much more in cycle 2 and beyond.
But are you saying that you generally put people in the hospital for 28 days to get aza-ven?
Yeah, we've actually always put patients in the hospital, older, unfit patients. Remember, these are 70 or 75 plus patient populations. And again, this is not something necessarily done across the country, but that's also because of the patient profile. So majority of our patients come from long distances, from faraway areas in Texas and Louisiana and Alabama. And it's really hard for them to come drive 3 times a week for blood work from 7, 8 hours away. So because we have such a wide catchment from outside of Houston, we often admit them for the initial hydration, tumor lysis, blood count monitoring, transfusions for cycle 1. After that, we do everything outpatient. Now, if a patient were living in Houston, local, very compliant, can come for labs routinely, we may consider not doing that. But in general, that has been our approach, and it's been quite safe.
I mean, I always assume that in general, in the community setting and other academic settings, that people generally don't get admitted for aza-ven. Am I wrong?
Actually, I think most academic settings do admit them. They may be for different periods of time. Some admit them maybe for 2 weeks, some admit them for 4 weeks. But most academic settings that I'm familiar with, especially for those older than 75 or 70, actually are admitting the patients initially. I don't know for sure in the community. I think some of them do admit for the first cycle, some don't, but this is only for the first cycle, and many do admit. In fact, the recommendations from most guidelines are to admit for that first cycle, including from the NCCN.
One other thing I was going to ask you, when you were talking about FLT3 and you were starting to get into the mechanism of resistance, I was sort of triggered a memory. In one of the early studies, I can't remember if it was sorafenib or midostaurin, where like it looked like they saw benefit in FLT3 unmutated. And is there any reason to think that people who at least start out unmutated might benefit from these drugs?
Yeah, this is a great question. And there is data, actually, very recent data that has come out with quizartinib, in fact, in the wild type FLT3 mutated patients. And this is something we had seen initially in the phase one about 10 years ago, whereas a single agent quizartinib had activity about a 30%, in fact, overall response rate in relapsed refractory FLT3 wild type. And then recently, the Spanish group have looked at quizartinib in combination with intensive chemo in frontline newly diagnosed patients who are FLT3 wild type, and showed actually a significant survival advantage with quizartinib added to intensive chemo versus placebo intensive chemo in a wild type population. So this is something that is being explored further with larger planned studies coming. But we do think that this may be due to two things. One, there may be off target other mutations or other pathways that are inhibited by quizartinib. We know, for example, Sybil is one of them, maybe PDGFR others. And the second is we actually do know that even in the FLT3 wild type, without the mutation, there is upregulation of FLT3 ligand. This is lower than what you see in a FLT3 mutated. It's about 10-20% compared to what you see in a mutated FLT3, but it's there. And so if you have a very powerful FLT3 inhibitor, it may actually be able to suppress that FLT3 ligand expression even in the wild type and get you some activity. So I think these drugs may not be truly just FLT3 inhibitors in the future. They may have a wider scope. So moving on, then, how do we move beyond just the HMA-VEN? We are getting survivals of 14 to 15 month median, but the 3-year survival, as I mentioned, is 25% or lower. So one approach could be to add targeted therapies for those who have a targetable mutation. So potentially adding a FLT3 inhibitor like gilteritinib or quizartinib, or adding an IDH1 or 2 inhibitor, or potentially adding an antibody drug conjugate. But what about those patients who do not have a targetable mutation like FLT3, IDH1, IDH2, MLL, and PM1? This is still about 60-65% of the patients. So for this group, our group, led by Dr. Kadia, has made an effort to look at new backbone combinations that may further enhance both response as well as depth of response, MRD clearance, and overall survival in this older unfit population. This regimen is called the cladribine, low-dose cytarabine, or triple nucleoside regimen. And here you see the most recent data that has been presented at the ASH meeting last year, where this combination has shown very striking response rates, a CR/CRI rate of 92% with a true CR rate of 75%. Remember, with AZA venetoclax VIALE-A, the true CR rate was 37%. So this is quite a significant higher CR rate, and the MRD negativity was 81%. But it is a single arm study, so that does need to be confirmed. However, given the number of patients we have treated now with close to 120 patients, and the survival continuing to look much better than what we have seen with HMA-VEN, this has now become our regimen of choice for patients who are 60 to 80 years of age in the frontline setting who do not have a targetable mutation like a FLT3, IDH1, IDH2, MLL, and PM1, and the 2-year survival is about 65% compared to 25-30%, as I just showed you for the HMA venetoclax. And hopefully there will be randomized studies starting in the future to confirm this survival and response benefit. Just showing that the response seemed to be across all different molecular groups, and there was a robust survival in both ELN intermediate favorable, but also in the ELN adverse, where historically HMA-VEN has not done as well, with median survival less than 10 months. Here, the median survival was 24-25 months. So I think this may be a new regimen emerging that could have a higher activity response, depth of response, MRD, and potential survival benefit, especially in that intermediate adverse group, than what we have seen historically with the HMA venetoclax regimen. Now, the other question I get a lot from doctors, both in community and academics, is How long do we continue azaven? Is this a continuous therapy like blood pressure medications that you take it for the rest of your life if you have hypertension? Or is there a way to stop this treatment at some point? And if there is, what molecular markers or MRD markers or response markers can be used to choose patients most suited to stop. So this was something that the French group led by Dr. Sylvian Garcias looked at in a retrospective analysis across the Philo Cooperative Group centers as well as the U.S. Moffitt Center contributing some patients to this. This was across the last 5 years. These were patients who were adults who received aza-ven and were in a remission, either a CR, CRI, MLFS, and patients should have received at least one or more cycles of the treatment, and only those who had discontinued treatment more than 3 months before the time of the data cutoff were included. And the key questions here were, number one, what is the profile of these patients who stopped? What you see is that these were predominantly frontline patients, which makes sense because in the salvage setting, we are much more nervous to stop something we know inherently this is a more difficult biological group. Patients had a median of 4, but some of them up to 15, 17 cycles. They all had some form of response. Majority were actually a full CR, 80%, a few of them with MLFS, and a lot of them, almost 78%, had MRD by either a flow or molecular analysis. And the reasons for discontinuation, I think this is quite interesting and something that matches what I have seen in practice, were predominantly due to prolonged cytopenias, what they're calling hematological toxicities. So almost 60% of either the patients or the physicians decided to stop treatment because they were finding that the counts were not recovering, putting patients at risk of infection, bleeding, other complications. In a few others, this was due to patient preference or due to a comorbidities, weakness, and fatigue. And this is similar in the frontline and the relapse group. So, what was the outcome of stopping? Was there benefit? In fact, yes. Correction of cytopenias was seen in 60% of those patients. So, a lot of those patients, 58%, stopped due to cytopenia, and a large proportion, 2/3 of them, seem to have recovered their counts after stopping the aza-ven, which biologically makes sense. Once you're off the venetoclax, we do see a majority of the patients will recover their counts within the next 2 to 3 months. What was really interesting, I think, is the median overall survival. So here, the median overall survival after stopping in these patients with CR, CRI, many with MRD negative, was 44 months. So in fact, remembering that these are 75 plus patients, this is quite good, 3 to 4 year survival even after stopping. And again, retrospective analysis. So it's suggesting, not definitive, but suggesting that there may be a group of these patients with deep responses who have achieved a full CR, who may be able to stop treatment at some point in time with a good maintained overall survival, as was seen in the study. Now, the relapse is a little bit more tricky. Here, majority of the patients do seem to have relapsed. Median overall survival is lower, and so you may want to be more cautious. So the conclusions here is that discontinuation of aza-ven in patients with the CR/CRI, especially those who are MRD negative, may be feasible, especially in those who are having prolonged hematological toxicity, and there is reversible of the cytopenia after stopping the treatment. A very encouraging OS was seen in the frontline population of 44 months in that specific group of patients who stopped. But I think this needs to be looked at in a prospective trial, and I do think that this is something that is being looked at by the French group and potentially by others in the future. So now moving on to other combinations of venetoclax, we talked a lot about the HMA venetoclax, cladribine, lotilaner, RC venetoclax, or HMA venetoclax triplets, adding FLT3, IDH1, IDH2 menin inhibitors. But what about for younger fit patients? Because all of those are focused on older, 70, 75 plus, or those with severe comorbidities. However, still about 50% of our patients are below 65 years of age and fit, can receive intensive chemo. However, intensive chemo alone gives us a 3 year survival of about 35-40%. Can we improve on that? So to this effect, we started looking at combinations of adding venetoclax to the backbone intensive chemo that we have been using at MD Anderson, either the CLIA, cladribine, idarubicin, cytarabine, or the FLAG-IDA, which is fludarabine on a similar backbone of idarubicin, cytarabine, with venetoclax added for a 7-day period only to avoid very severe myelosuppression when added to backbone intensive chemo. So these data were published at the end of 2022 and updated last year. What we see is overall the response rates are very striking across the board, 86% with the addition of ven to intensive chemo compared to 60% with intensive chemotherapy alone. A large number of these were MRD negative responses. And what we see is that with transplant, there does appear to be a survival benefit with intensive chemo ven versus intensive chemo. But even in those who did not go to transplant, there appears to be that survival benefit. So this regimen seems to be very potent, the addition of ven to intensive chemotherapy. And here, just looking at the event-free overall survival on a propensity matched analysis within our population at MD Anderson, when we compared intensive chemo ven, 64 patients to those who received intensive chemo alone in the past 162 patient, we are seeing a signal for event-free overall survival improvement. So another regimen that is going to be taken forward into randomized phase 3 studies. A number of these are actually now being developed and started, but suggests that ven may not be restricted to older unfit population. It may have benefit and implication even in younger fit patients. So that brings us to one of these studies that kind of emerged from this data set that we had started to put out from MD Anderson. This is from the SAL group in Germany, led by Dr. Christoph Rohlig. The data was presented by Leo Runk at the ASH meeting a few months ago in December 2023. The study is called the RELAX study. Here again, they're using an intensive chemo backbone, adding venetoclax to it. The backbone they use is slightly different. This is called a HAM regimen, which is looking at cytarabine and mitoxantrone given for 3 to 7 days with venetoclax added for 14 days. So same concept, adding venetoclax to intensive chemotherapy, however, different chemotherapy backbone here with cytarabine and mitoxantrone. First, the study population. This was, in fact, just the phase 1B part. The study is now moving on, continuing in phase 2, and there will hopefully be more updated data coming in the future. But these were younger patients. These were a median of 26 to 74 with a median age of 54 years. So this is not the older, unfit 78, 79-year-old population that we talked about with HMA-VEN. And these were predominantly relapsed, but also some primary refractory AML, with a number of them having received previous induction chemo or previous transplant, and about half of these would fall in the ELN adverse. So this is kind of like a real world population that we would see based on the molecular ELN and prior therapies. Overall, the regimen is quite tolerated. I will say one of the big concerns that people have is how can you tolerate these intensive chemotherapy with ven regimens? But I do think with appropriate reduction of the venetoclax to 14 or even 7 days, and with good academic or centers that are used to managing neutropenia, infection, count recovery, sepsis, transfusions, this is feasible. This is something that they were able to show in this cooperative group study across 30, 40 centers that, yes, there was febrile neutropenia, infections, sepsis, but these could be managed. And the 60-day mortality actually was only 5%, which is similar or even lower than has been shown in relapse setting with intensive chemotherapy. So I do think feasibility was shown. And then, of course, the key question is, what is the efficacy of this regimen? And this was actually really quite striking. The CRC rate, remember, these are relapsed refractory patients, was 82%, with half of these as a CR, half as CRI. And especially in those with ELN favorable intermediate, there was a very, very high response rate. So all in all, for a relapse population, this is really quite encouraging. This is very similar to the FLAG-IDA ven relapse data that our group had published a couple of years ago, showing CRC rates of about 70, 75%. And this is kind of a confirmation of that data. And the overall survival now at 2 years is 60%. Again, this is something we have not seen in relapse refractory patients, except for with intensive chemo ven based regimen. So I do think this is quite a nice signal. But again, only 38 patients, so we do need to see more data. And as I understand it, the SAL is expanding this further. So what other options could there be for adding to intensive chemotherapy? Is it just venetoclax? In fact, we just discussed this briefly. Dr. Love brought it up. Could we look at other drugs that could enhance activity in a non-targetable mutation population? And one of those that's quite interesting is a drug called quizartinib. So here what I'm showing you is actually the survival curve from a study called the Kiwi study that was presented by Paul Montesinos at the European Hematology meeting in 2023, where they added quizartinib, which we think of traditionally as a FLT3 inhibitor, but they added it in non-FLT3 mutated patients to the backbone of 3+7 intensive chemo, and the comparator was placebo with 3+7. And in this non-FLT3 mutated or FLT3 wild type group, they showed quite a striking overall survival difference at 2 years and ongoing with the addition of quizartinib. So this is kind of a little bit of a surprise, not something that I think we all expected, given we thought that quizartinib is mainly a FLT3 inhibitor, but appears there may be additional impact of quizartinib beyond just hitting the FLT3 mutated population. This is just showing that, especially in the intermediate ELN, there was a clear benefit of adding quizartinib to 3+7 versus placebo 3+7, and this is something that is being evaluated further. In fact, this is a point I would like to make, and I think will be discussed by my colleague Dr. DiNardo as well, is there is now an effort to generate something that I think is quite cool called a FLT3-like signature. We've seen this done in ALL, where we have a Philadelphia-like signature, which identifies patients who don't have the BCR-ABL or Philadelphia chromosome, but on RNA gene expression have a profile that exactly looks like a BCR-ABL rearranged. And in some of those patients, using BCR-ABL inhibitor works. And so the same analogy here is that these patients don't have a FLT3 mutation, but they seem to have a gene signature using RNA nanostring that matches exactly FLT3 mutated, and were also the same patients who benefited with the OS with the addition of quizartinib FLT3 inhibitor. And these could make up to 30% of the non-FLT3. So if you say 30% of patients have a known FLT3 mutation, another 30% could have a FLT3-like signature benefit from quizartinib. That could mean that close to 50-60% of frontline AML could benefit from the addition of such a kinase inhibitor like quizartinib, which could be very meaningful.
So was this trial a phase 3?
So it was actually, they called it a randomized phase 2, but it was a pretty big study. It was 250 patients, like 120 on each arm. But it was done only in Spain. It was a Spanish Fatima group study. So we don't know yet how this will impact the NCCN and the FDA, but there may be other larger similar studies, globally that could come in the future, is what we think.
Are you aware of any ongoing phase 3 study right now looking at it?
Not yet. No, not yet. But I think hopefully in the future. But we do think that this data is pretty striking. As you saw, the survival difference is quite large. So I definitely think that it would be great to do a confirmatory study, and I think very good chance that study would be positive. There was nothing in the Spanish data that said that raised concerns. The population seemed to be very real world like. So yeah, I think hopefully it would be nice, and that could then expand the use of a drug like quizartinib, tyrosine kinase inhibitor, from 30% currently to maybe 55-60%, and benefit some of these FLT3-like patients. I think it would be very nice to get the signature used in the future. And so along with doing the studies, it would also be nice to see if we can actually develop an RNA signature that could then be CLIA validated and used in the future, kind of like what we do for Philadelphia-like ALL. Yeah.
Fascinating.
It is very interesting, yeah. Okay, so now moving away from venetoclax and targeted therapy approaches to immunotherapy, an area that I'm really interested in, an area that is still in its infancy in AML, but I think it will continue to grow. A lot of interest, a lot of efforts, a lot of pharma, a lot of investigators moving there. So the first approach is using antibody drug conjugates. This is something that has been successful across many heme malignancies, ALL with inotuzumab, multiple myeloma with BCMA targeting, lymphoma with CD20 targeting, and AML with CD33 targeting, gemtuzumab already approved. However, we think that there is a avenue to improve beyond gemtuzumab with the use of new antibody drug conjugates using a better payload, using better linkers, and better cellular uptake. One of these is a drug called pivekimab, also previously called IMGN 632. This has now been evaluated in combination with azaven. It was initially done as a single agent in relapse setting, where it showed about a 25-30% CR/CR rate as single agent, which was not thought to be sufficient to go for full registration. So we decided to move it up front in combination with HMA-VEN to see if we can improve that depth of response, CR rate, and OS. The nice thing about this agent is the safety profile. It's actually been very well tolerated, and compared to other CD123 antibody drug conjugates that are out there, such as tagraxofusp or bispecifics, such as the ones we have used in the past, flotetuzumab, we see very limited capillary leak syndrome, severe edema, cytokine release, or VOD. So I think that really separates this agent in our mind from the others. The safety profile compared to all of the other ADCs in AML seems to be favorable, and we are seeing good responses. As you see here, 50 patients were presented at the ASH meeting with a MRD negative CCR, which is CR plus CRI rate of 76%, which looks better than the 40% or so CCR MRD negative rate that has been shown historically with HMA-VEN, and responses were seen in those three populations, lower benefit, intermediate benefit, high benefit, at a higher rate than what has been shown with HMA-VEN. But eventually, this will need to be confirmed in a randomized study. We're still enrolling with the triplet in the front line. We hope to present updated data at the ASH meeting this year with a larger frontline single arm data set, and then hopefully eventually move to randomized studies. This drug is also being evaluated by one of my colleagues, Dr. Pemaraju, in frontline BPDCN, blastic plasmacytic neoplasm. And we think that that may be an area where it could actually have a path to quicker registration because it's very safe. It does not have capillary leak or CRS that has been seen with the other approved agent in BPDCN, and may actually get there quite quickly through Dr. Pemaraju and our efforts. And then lastly, about immunotherapy, I'll talk about another CD123 NK cell engager. This is a phase one, very early. There has been a lot of efforts to develop bispecific engagers or immune checkpoints that can harness the body's innate or adaptive immune system to attack the leukemia cells, very similar to the successes seen with solid tumor immune checkpoints or bispecifics in multiple myeloma or in lymphoma. And a number of those using T cell targeting bispecifics in AML unfortunately failed either due to lack of efficacy or due to severe toxicity, cytokine release syndrome, and were aborted. However, now we have moved away from T cell adaptive immune harnessing in AML to more of NK cell or innate immune system harnessing. And this is one of those first approaches using an NK cell bispecific that targets CD123, which is a common antigen on leukemia cells, along with a NK cell target such as CD16. And this data was presented at the ASCO meeting in 2023 by Dr. Anthony Stein from City of Hope. Again, here showing that this is a what we call trike or a triple engager that targets CD123 on the surface of the AML leukemic blast, and then CD16 to engage the NK cell, which is a component of the innate immune system, as well as working on an NK activating receptor at the same time. So not only engaging the NK cell, but activating it through the NKp46. So this approach scientifically sounds like it would be very sound, has now gone into a clinical trial in the phase one, and very good to see we are seeing single agent responses. This is kind of the swimmer plot of responses across dose levels 1 through 8. Overall, the responses were seen mainly in the dose levels 3 and 4, as you can see, as well as dose level 8. There were 2, 1, and 2 responses, CRCs, which you can see on that bottom row. And interestingly, at those patients who were treated at the higher dose levels, which were considered to be 1,000 microgram per kilo infusion, we are seeing 5 out of 16 confirmed CR/CRI, which is pretty encouraging. Of course, early, and we need to continue to see this data. The phase 2 is ongoing with expansion. I anticipate it will be presented at one of the large meetings in 2024, either in the summer or ASH later this year. And we're also looking at a number of immune correlatives as well as future combinations to further enhance this NK engager, whether it's to be combined with NK cells or combined with venetoclax-based approaches. So I think there may be a lot we hear about this, hopefully, in the near future.
So do you see like CRS and other CD3-like side effects with this thing?
Yeah, we do. So to your point, Dr. Love, yeah, we do see CRS with this, and this was also seen at the doses that were active, not surprisingly. So once we got into that 1,000 microgram or higher, we started seeing CRS in patients. It seems to not be a super high rate, but it's there. Now, infusion-related reactions are seen. These can be seen in 50 to 70%, and we have seen some of these that can be grade 3-like. So you do have to monitor these patients, whether they're admitted for a couple of days or close outpatient ambulatory infusion monitoring. And if we start seeing any infusion reaction CRS, we usually start steroid quickly, or we'll start with Benadryl, Tylenol approaches. And that seems to have worked in all the patients. I haven't seen anywhere we could not control the infusion reaction CRS. But exactly as you're asking, that is the expected and on target toxicity to be managed, which it seems to be manageable. Now, just a couple of other interesting things. We didn't talk too much about MRD, measurable residual disease or minimal residual disease, depending on the publications you look at. But I think this is becoming something more and more in the forefront and interesting in the acute myeloid leukemia space. So I thought this study was really quite interesting. This is now looking at molecular MRD using a high sensitivity PCR for NPM1, which is probably the most established MRD marker among the molecular markers in AML. And these authors actually were able to pool data sets from two large UK AML 17 and 19 studies and showed that in patients who have a NPM1 positive after induction chemo, the induction was daunorubicin cytarabine based, there was a clear benefit for allotransplant. So NPM1 was a molecular MRD marker that could predict those patients who clearly needed allotransplant and benefited from it, whether it was in terms of overall survival, relapse-free survival, or relapse. On the other hand, and I think this was the most interesting thing, in patients who did achieve NPM1 MRD negative after induction consolidation, there did not seem to be any benefit from allotransplant, whether it was in terms of overall survival. There was some benefit in relapse-free survival, but I think the point here is that even though you get more relapses without transplant, NPM1 is sensitive and you can salvage them effectively. And so the OS in the end seem to be similar, but basically highlighting that in the future, there may be strategies to select patients who need transplant using NPM1 as a MRD marker. Also, interestingly, one may ask, well, what about if they had a concomitant FLT3? Because this is seen in about 50% of NPM1 mutated. Did this matter? And overall, it did not seem to matter if you are NPM1 MRD negative. Those patients seem to have a similar OS, whether or not they had a concomitant FLT3 mutation. I think the key limitations of this study, and which is why this is not something that we plan to implement right away, is that a lot of this data was generated before the era of FLT3 inhibitors. These studies were 7-8 years old. And also, we don't have a FLT3 MRD assessment on this. So we're not really sure how we would do that, because today we are adding FLT3 inhibitors and using FLT3 MRD assessment for most of our patients.